Hi, everybody. Welcome back to the Prehospital Paradigm Podcast. As you know, we like to take our show on the road, and today we are at Parma Fire Station 2, and we have Captain Ricky Fetter that is going to welcome us into their fire station. They gracefully welcomed us here, and we're going to talk everything trauma tonight.
All right, welcome to Parma Fire Department, Station number 2. My name is Ricky Fetter. I'm a captain here on the fire department. I serve as the fire marshal and the EMS coordinator of our department. We're a 112-member department, 5 stations, which covers 20 square miles. A lot of people don't know that we're the 7th largest city in Ohio and the largest suburb in Ohio. We average around 16,000 plus runs a year, with about 10,000 of those being EMS runs. So I'd like to invite everybody to listen to tonight's discussion about trauma, and certainly here in Parma we get a lot of traumas. I'd like to thank Chief Lasky and Dr. Dussel for allowing us to have this happen tonight at Parma Fire Station number 2.
Thank you. Thank you very much, Cap. Thanks for having us here. Couple things we want to get out of the way. We want to thank AT&T FirstNet, one of our main sponsors, along with Cradlepoint. This is how that we're able to stream all of this data and get it out to you. It's everything Caleb and I do not understand how any of the IT works, but we have people that are a lot smarter than us that figure that out. Other thing to remember is that we offer free CE in Ohio, so you can go to our website, watch the episodes, take a quiz, and you're able to get free CE to help you renew your certification. And we also want to remind everybody of your local blood drives. So one of the initiatives that have been we've been pushing is local blood drives. All the trauma centers obviously need blood. We're going to talk about blood products a little bit more tonight. But if you're able to, donate blood in one of those locations that's near you, every hospital would greatly appreciate that. So without further ado, I'd like to introduce our guest of the hour. I have Dr. Glenn Tinkoff, who serves as the System Chief for Trauma and Acute Care Surgery. He is the Vice Chair of Surgery at University Hospitals, and he is also a lead site surveyor for the American College of Surgeons Committee on Trauma. We have Caleb Ferroni, and we also have Dr. Hill tonight. So we're going to talk a lot about trauma. Hopefully all of you have watched some of our recorded sessions. And we actually started about how Dr. Tinkoff started out as an EMT back in the day, as he put it. But he's familiar with pre-hospital care. And
yes, I'm familiar. It's probably a good almost 40 years ago. But oh, it does. It does. It was a lot of physicians get their start, especially in the trauma side, get their start as EMTs. I was in college in Williamstown, Massachusetts, and pre-med, and decided that this would be a good time to learn a little bit about emergency medical management. At that time, that was a long time ago, but that's where you learned basic first aid at a level that it was being applied, and then making the first runs were impressive. And watching the fire service work along with us was impressive as well. Sure. And so for my years in college, that was one of the best things. I wish I could have got paid, but
I understand.
But it was a volunteer service, and it was wonderful.
That's awesome.
And hanging out in the firehouse, you just felt like you were in a community.
Sure. Yeah, the camaraderie and the family type structure.
And you also got to know the community.
Yeah.
More than a college student ever would. So
that's a great point. Yeah. And a lot in the background everybody's going to hear is Parma's been extremely busy today. We lost the majority of the crew at Station 2 pretty much right before we started to a bunch of calls. So that's a usual thing for us whenever we go somewhere. It seems like they get a bunch of calls.
Okay.
So we're going to start off with just talking about trauma centers in general. Dr. Tinkoff, I know we talk a lot about the different levels, so could you give maybe a quick synopsis about, what's a level 1, what's a level 2, what's a level 3, and kind of the differences between those?
Yeah. Yeah, well, and that's good to stick to those levels. That's those that are designated in the Ohio trauma system. Yeah, the level 1 is a regional resource center, and is required to have all the resources to care for the injured patient, all injuries. However, there is some caveats, and we'll go through those. But,
Sure.
But all injuries should at least be able to be managed, resuscitated, and taken care of at that hospital until, like a burn patient, would go to a specialty care hospital for burns.
Sure.
Sometimes reimplantations have to go elsewhere with their limb to be reimplanted. But the fact is a level 1 hospital also has an academic mission. So that mission and a research mission. So those have to be generally surrounded by really a university or some kind of academic component to their mission, and move it forward from there. That brings fellowships into play, as well as residents and trainees. So you're constantly educating, teaching, and creating a next generation of trauma files.
That's awesome. Yeah.
The level 2 has all this. It should have all the same resources, especially the clinical resources, but doesn't necessarily have the academic mission, and certainly doesn't have the research mission.
Gotcha. Okay.
And it's not investigating and moving the field forward. Not that they're generally large hospitals in busy communities, or they may be the only hospital in a rural area of the country that has all the resources, available. Often seen in the Dakotas and so forth. That's your in Montana. That's your major hospital, resource hospital. Level 3s are the unique element. I've made a life's work of developing level 3s. When I was in Delaware, we really created our trauma system around community trauma centers. And one of the problems with an exclusive system with a level 1 or a level 2 taking all the trauma patients is that the skill set is lost at the community hospital. Nobody takes care of trauma patients. Now, trauma patients are injured patients, and there should be a subset of injuries that can be cared for at a level 3. You usually have an orthopedic surgeon and a general surgeon. They can do a modicum of care. Emergency medicine is usually very good at most level 3s, and they can do a whole host of trauma-related resuscitative procedures, as well as manage and understand how to manage. And most trauma patients don't need prolonged hospitalization or hospitalization at all, but they get transferred to the level 1s. In Northeast Ohio, that's moving them into the city, right?
Sure.
Either University Circle or Metro Health in its area in Ohio City, and those are changes for the family and difficulty, and often they only have a 1 or 2 day stay because they have moderate to minor injuries that they're being shipped for, such as a small head injury, traumatic brain injury. So level 3s and fractures. The level 3s work very well, but they need some commitment, and they need a programmatic approach.
Yeah, and I mean, you oversee that here for all of us, and we have a lot of successful level 3s, and a lot of those, like Dr. Hill at Portage, they're the only hospital in Portage County. Yeah. Geauga Medical Center is the only hospital in Geauga County. So those level 3s play a critical role in getting, the EMS takes care of the patient. We get them to a level 3 because we need more of those resources. We need, we need Dr. Hill. Maybe we need that general surgeon. Maybe that patient needs mass transfusion protocol or stabilization, and then might get transferred. But it's a huge part of that. And a couple of things you said I want to touch on as well that, Jack is here, which is Parma's program manager. So we're in Parma. Parma is a
We know each other pretty well.
yeah. So UH Parma is a verified level 3 trauma center. We're in Parma. I think that's a big thing to talk about. But you also said that too is because these people live in the community. So even when I'm driving here, I told Jack where I'm driving and this is how I'm going, and he told me I probably shouldn't talk on the phone because I'd get in a car accident on the way here, which was almost true. But those are the things that the level 1 and with research and education can also bring out and branch out to our local centers. And I think a lot of our trauma program managers and EMS as a whole, all of our squads that are under our medical direction and the trauma program managers do very well is, with injury prevention, because injuries in Parma, like we had talked about earlier, might be a little bit different than Giaga, or injuries might be a little bit different in Portage because they're just different communities. So being familiar with your trauma community and your high levels of injury that are coming into your center are big, and plus people want to try to stay. Patients want to try to stay in the community and be treated in the community if they can, and that keeps them close to home. Going to Cleveland, whether it's CMC or it is Metro, that's very intimidating to a lot of people that might live out by Portage. To now I have to drive an hour. I'm not familiar with it. I don't know where to park. That's intimidating to maybe that family member that their loved one just left on an aircraft. Things we don't really talk about a lot in EMS, but I think it's huge for the patient.
Well, I look at it this way. Parma. Recognize that UH Parma has been recognized by the American College of Surgeons Committee on Trauma as a model level 3 trauma center. So which floored us when we heard that they don't often give compliments, and that was in the report that they got back from their last visit. So it's recognized that you have something special here, and we recognize it at UH as a place that does it right as a level 3, and is working in its community. And you heard that Parma's the 7th largest city in itself. It is a city, and the community wants to go to its hospital.
Sure.
And wants to stay local and wants to be cared for afterwards locally with rehabilitation and recovery. That's the goal here.
Yeah.
You come down to CMC, you're not going to be seen afterwards at CMC generally. You will have to find your resources to recover outside in your own community, often making it much harder to do so. When we release you from the hospital after a 5 or 3 week hospitalization, you're not recovered. Recovery takes months or years sometimes, or never. And you have to live with the injuries you have. And that's one of the really not the failures, but one of the downsides of injury is that it takes a long time to recover from injury, especially the mental aspects of injury, post-traumatic stress, and so forth. With that said, I think we have several level 3 trauma centers that have the same model that Parma has, and they all operate in a similar fashion, and they do very well for their communities.
Sure.
Lastly, the impact is on EMS too, because the EMS service wants a hospital they can go to. They don't want to be out of their area.
Their coverage area.
Yeah, their coverage area. They want it. That takes them away and unable to respond to their community, and that does sometimes need to happen. But we're lucky to have these level 3s positioned in the right places within the Northeast Ohio area to service a large portion of the region.
Yeah, I agree with you.
Especially level 3s. I mean, with traumas, even if we're just looking for an airway or blood product, I mean, we can stop there. They'll stabilize, and
Yes.
And like you said, it gets us back into our communities quicker too. And I mean, Geauga's even a bit unique because they have the Amish population.
Oh, yes.
And they don't want to travel all the way down to CMC either. So the more that they can stabilize there and handle there, it's definitely a benefit.
Yeah, it's one because they come with the whole family.
Yeah.
And,
Generally good food too.
They're wonderful people.
Wonderful people.
But it's
Just a different culture, and it's
it's just when they will take most of the waiting room. Yeah.
So we're talking a lot about the American College of Surgeons. We're talking about Parma. We're talking a lot about level 3s. Can you give us maybe like a 20,000-foot view of? We always use this word verified. They're verified, levels. So could you give us maybe like a 20,000-foot view of what that that verification survey looks like?
Yeah, after having just done a review and doing one next week, the simplest way to say it, it's making sure that the reviewer is making sure you're doing what you said you do.
Gotcha.
All right, so you might have put it on paper, but we want to see it.
Yeah.
And if you can't show it, then it doesn't exist.
Yeah.
And most of it's showed in documentation, but we have a tour, and we want to see that. And if you watch the development, like Jack's center is, you watch the development of a trauma center. It takes about 5 years to get the culture. Because, when you're not a trauma center, you don't want to do. A good portion of the staff is, and our non-trauma centers often say it, the staff there, I don't want to be, take care of injured patients. But once they learn how to be, an excellent trauma center, they have an ethic in the atmosphere that resonates that throughout all departments, and it elevates the care in the hospital.
And pre-hospitally too, I think. Is a huge portion of that.
No, and EMS wants to go there.
Yeah, we want to.
When I was in Delaware, I knew there was something wrong when I went to the southern counties in their hospital and their EMS. I toured their fire departments, and they said I can give better care in the back of my rig than that hospital can. So I don't want to take that. And they used to call the state helicopter, because we used the state helicopter in to transport to us the level 1.
I think that's a big point you just made, that it has part of the culture.
Yeah.
And it has to be something that hospital accepts as part of that culture to change with it. And when you have that attitude and the mentality of saying that this is us, then I think that goes a long ways.
Yeah. You're absolutely right. Yeah.
And I think too, you see it pre-hospitally as well. A lot of our protocols are developed that way. We're going to talk a little bit about. We're going to talk a little bit about ANSEFT and how we're trying to lead the way in open fractures as a system, and that is the relationship between EMS playing a pivotal role in that trauma patient's care, part of the system, and I think it's one large culture. Yes, even outside the hospital, I think it's huge too, and I think that was your point you were trying to make there. I think it's great.
Yeah, and I think that, that's why we've developed a trauma system, and that's what a trauma system is the ethic is through the system. So even the non-trauma hospitals now get it, and they now participate as non-trauma hospitals. So they know they have backup all the time, and they'll keep patients as long as they know there's a place available to move that patient if necessary.
Sure.
It's really neat to see too. I mean, and Scott can tell you in the paramedic curriculum how things are changing too, that we're now educating people on seeing, this is a trip hazard, this is that, and we're trying to prevent this trauma from even happening to begin with.
That's great. Injury prevention.
We've got community paramedicine programs that we're going out and talking about, and putting grab bars in our frequent faller homes, and making sure rugs aren't on top of carpet, and doing all those preventative stuff.
Yeah,
And just other agencies starting to work with us so well. Department of Aging, if we flag an elderly patient that, like you said, needs a grab rail, they'll come out and install it, and it's been phenomenal. I had the other day one of the residents we have a really big it's not at a nursing home, but it's like a 65 older community, and they called the firehouse to ask, hey, can you guys come back out and give us some lectures on what DNR means and what you want in the vial of lives and how we can save our, and it's just amazing hearing that come back from them, because they remembered that we were there to do that, and let's do it again. It's like, that's cool. That's winning.
Yeah, that resonates with them. Yes.
And we're very lucky, obviously, being in Northeast Ohio. We have level 3s. Just in UH's system, let alone we're part of a larger regional system as part of Northern Ohio Trauma Systems and NOTS. And we also have PED resources. So a lot of times we always talk about traumas, we talk about just adult. We also have, Rainbow Babies and Children's downtown, that's a level 1. We have Metro Health that does burn care for specialty care. So we're very lucky compared to other states, and sometimes I even take that for granted, when you look at the big trauma map on all the different centers across the United States.
Well, even in Ohio, southeastern Ohio struggles, and some of the trauma care that they have to receive is in West Virginia because, they just can't, they don't have the infrastructure down there and the hospitals down there to support that level of trauma care.
Sure.
Northeast Ohio is very lucky. I mean, and it's been lucky for a long time relative to trauma care. Metro Health was a leader in trauma care, and as a public hospital, was the model that most cities, urban centers depended on. When I actually was at Philadelphia General, there was a general hospital there. That was a public hospital, and that's, unfortunately, in that time frame, those who were treating you were trainees. And you just got to remember that. This was quite a long time ago, but it was last century. But but that was who was there. An attending would come over once a week, and you listen to your chief resident. If and I was a chief resident in this system as well, so you had a lot of independence in those rotations.
Gotcha.
So university hospitals and even my med command extend all the way into Harrison County, which is central South Ohio, and they often call helicopters to their sites.
Yes.
And it's WVU that picks the patient up and takes them over to West Virginia. A lot of times where they're going to fly them to Altman.
That's
if
right.
If it's closer, but they're it's going to be an hour and a half by ground, so they use aircraft a lot for their trauma patients.
Yeah, and some listeners might, that's a good point. A lot of times we talk or focus on ground, because we're obviously very close to level 3 because we're in Parma. There's a level 3 right here in Parma, but we're also
level 1's 5 minutes up the road.
Yeah, and we're not far from a level 1 all by ground. But as you get more rural, you might be utilizing aircraft to transport that patient to get them to that center, and that aircraft's also bringing resources too. So if you're in a rural community and you're listening to that, that aircraft's going to bring blood products and stuff to you, and some higher level of care. You can transfer care to them, and they'll get to the appropriate center in the right amount of time.
Yeah, it's important that this allows for proper distribution of patients. You remember, we're dealing with capacity issues at CMC all the time. Metro is doing the same thing. We're carrying services that number sometimes in the 70s and 80s, and basically, people are just staying in our ED often to be discharged a day or two with minor injuries. If we can keep those individuals in their communities and give them the care that they have and the recovery they need in their communities, we're much better off.
Sure, and it takes pressure off the the mothership, if you will, the main hospital, level 1.
Yeah, for high level trauma care, that's what you want the level 1 rate for.
Sure.
We do a very because of the type of services we run, we don't provide the attention often an elderly patient will need. We just don't have the staff to do that because the nursing ratios can be at night sometimes 1 to 6 or 1 to 8. And they're not going to get around to the room to talk to patients and families, they're going to basically have to, run through their shift.
Yeah, and see all their patients.
Yeah.
It's a challenge.
Yeah.
All right, well,
We've even developed our system such that if we've got certain type of head bleeds that are in the community, that we don't even transport to level 1 center. We keep them in our ER.
Right.
We talk to local trauma. We talk to.
Sure.
We'll keep them there. We do a 6-hour stability scan. We recheck with trauma. Say they're clear to go home. They just do outpatient follow-up, and that way it saves them that second ED. It saves them that transportation. We can do all that monitoring in the emergency department, keep them at home, and
Yeah.
discharge them back to their home and have close outpatient follow-up with whatever local resources we
Yeah,
have.
that's a system-wide brain injury guideline.
Yes.
Yes. Yeah.
I was one of Dr. Tinkoff's trauma patients, believe it or not. I was a transfer from GEOG after totaling a motor vehicle accident. That was not my fault. But needless to say, I was part of that bigger system, was transferred
you're welcome.
downtown. I was taken care of by Dr. Tinkoff. And then, my follow-ups for spine were at Ahuja. My physical therapy was, it was in Concord. It was a lot closer to where we live, obviously. So that's huge. So we've talked a lot about systems. I think it's important to explain those, talk about those, kind of how we get there, the importance that the college plays in the role. UH having a trauma system is huge. Protocol development. So let's talk about EMS. Let's talk about some field care, right? So obviously, the care for that injured trauma patient in our world, right, for EMS is going to take place wherever the injury occurs, whether it's a motor vehicle accident, whether it's a same height fall in that patient's kitchen. That's where it all starts. And one of the first things that I know we talked about a little bit on the recorded session was scene times. The importance of not camping on scene, making sure we're getting that patient to definitive care in the appropriate amount of time. Obviously, we have a lot of things we need to do in the back of the ambulance and for the patient and protocols to follow, and I think all of our EMS squads do a tremendous job at that. And it's just kind of stressing the importance of not staying on scene too long, right? We want to get that patient to the resources.
Yeah. Especially with a bleeding patient, if you see the bleeding, get it in this day and age, get pressure on it, with a tourniquet on it, move that patient as rapidly as possible to a place they can care for those injuries, and it's a trauma center, and stabilize that. If you suspect, based on hemodynamics, bleeding, that's internal bleeding, you're going to need to get to a place, again, a trauma center, where they can evaluate and operate. Managing them in the field doesn't make sense if you don't have to do that. Now, occasionally you have to get an airway. Occasionally you have to stop the bleeding that's obvious, right?
Sure.
But you have other tools. The thing is in the back of the ambulance, you do have to think of things like TXA, like the tourniquet application, and if they're maintaining their airway, you place some oxygen on it, and just get them to the trauma center.
I think what we have to do is get out of the mindset that if you don't check every box that's on the trauma list as a paramedic, you're a bad paramedic. You might not ever get past the first 2 boxes,
You're right.
But like you said, ultimately, who does that bleeding patient need? They need a surgeon. And we preach that very hard now in class and even at our firehouse, that it's not a knock on you. If you can get an airway, if you can stop the bleeding, like you said, on the way, and let's say you don't get time to get TXA because you have 2 people, one's driving, get them to the hospital. They'll get that, and then they have a lot more hands there, hopefully, that'll help.
Yeah, that's a great point, because what it points to is what we need. What needs to be done is just to communicate.
Yeah.
So that report is so important.
Coming into the hospital
That's
from
right.
EMS.
Yeah.
Okay.
It's probably that transition is the most important information we can have, and often it's our crews often are stressed, and they're coming in, I was going to say coming in hot, but they probably are. Yeah. Well, they're coming in and they're revved up. They wanna, and they have to get their thoughts together to get it done. Staying in that ABC aspect and telling us what's been done and what injuries are suspected. But we have to be quiet and we have to listen, and that's the important part. I practice 60 seconds of silence.
Yeah.
We don't interrupt, and let's listen, and then we can have a give and take if we need more information. Right.
Yeah.
Usually an eyeball test, and somebody who's been doing this for so long, I can tell if the patient needs treatment right now or I got a little time.
Yeah.
And
Yeah,
so do you guys do.
We
Yeah.
push that as, I always call that the doorway assessment. And when you've been doing this more than a few years, you can tell if somebody's sick or not sick.
That's right, yeah.
And it's the same for you. And I know that Dr. Hill stresses a lot that at Portage, you take that time out for the EMS company that gets there, just hear them for a minute.
Yeah, once EMS arrives, it's silence in the trauma room because I want to hear what EMS is going to say. Yep, after they're done speaking, we have time for questions, and then we're going to start talking about what the care of the patient's going to be. Albeit if they're at least able to have that conversation. If you guys are coming crashing through with blood coming out of the airway, sometimes we don't have that conversation. We might have to wait until we establish the airway and then can have that talk. But there are times, and I had a trauma patient I sent to CMC recently, that I honestly didn't get past D on my assessment because I had a cold, pulseless foot that I was trying to work on. So I got all the way to that portion, I kind of paused, then had my trauma, because it became a full trauma because she was hypotensive. My trauma colleague came in, we worked it together and got the patient out, but I was stuck for the first 15, 20 minutes and up until my deformity and my circulation, and I'm holding the foot in the right position, working on that problem because I couldn't move past that.
I like to think that one of the things that the paramedics and EMTs in the field are really good at, and you would know this being former, they're good at quick assessments and good at exchanging information very quick. And I think one of the areas that we kind of lack in is nursing doesn't necessarily have that quick exchange. And so if there's one point out there that could really stress for that transition in the ED is let the nurses understand that the physicians need that few minutes with EMS to talk quickly. They need it too. It's the best interest of the patient that you exchange information quickly and then continue the torch to the next treatment area. But
Yeah, well, communicate. Yeah, our communication with nurses is often challenging as well. So, but they're the lifeblood of hospitalized medicine. They deliver the care for us as does our APPs. But that interface with EMS in that short time period, because we don't see the field, we don't know is to get that information and understand mechanism and trajectory and those things that may come out of what you say. And And that might be even as quick as, hey, doc, look at this picture I snapped of the car. Oh, yeah.
And that might do so much justice for you, just to see the mechanism, like you said.
And that can be done, the structure of a trauma resuscitation, the lead is, especially in an academic setting, the lead is usually a senior resident or a fellow. The attending's laying back. I'm laying back, so you can come up to me and, and I do. We'll sit at the doorway, and I got my eyes on what's going on, and if I have to intercede or say anything, my job is to basically coach at that time, and therefore EMS staying at the door, and I thank them when I'm there for their their service, and we go our way, but they'll show me the stuff. If I need to intercede, then it's a conversation.
I think most ER nurses are good too. It's not a knock on nurses. I think it's just the differences in how they're taught. The curriculum's a little different. Paramedicine and EMS is very fast paced, and it's very trauma oriented and triage oriented and checking boxes quickly, as maybe not so much in the nursing curriculum, but ER nurses generally after a year or so, they pick it up pretty quick.
Yeah, and they take TNCC and stuff too to bridge the gap, and those are some of the things that we combine our trauma care. But I want to talk about a couple drugs now. Not to shift gears a little bit. So we kind of
about drugs.
Yeah, we're talking about drugs. legal ones. Sorry. So we talked about bleeding control, tourniquets, our bread and butter, for trauma, needle decompressions, things we do. So let's talk about TXA a little bit, and how important giving TXA pre-hospitally has been. We've made some changes over the years. We initially started with 1 gram over 10 minutes in the field, and then we transitioned to 2 grams in the field, for that patient that's showing signs and symptoms of shock. They have either suspected internal bleeding, a high risk. We have obviously external bleeding that we can see. They have a low blood pressure. They're tachycardic. We obviously see the signs and symptoms of shock, and the importance of giving TXA to essentially strengthen that patient's clots that they are making to try to stop the bleeding from breaking is probably a huge point that we really pushed, I think, well in our system. The squads do a great job at giving TXA pre-hospitally, and I think that's helped a lot of patients over the years since we've really pushed that out in our system.
Well, we hope so. The data that is out there is pretty irrefutable now. It's taken years. It came out of a military experience with TXA. The Marines were carrying it with them, and this was in the conflict, the Iraq and Afghanistan conflicts it came out of, and this is the standard now. But to push it out into the field like they had it in the field, the military, was a struggle, and mostly because. We have to be careful of putting another task on our EMS providers, especially in short transport times. Because again, it's airway, breathing, circulation, and bleeding has now, rightfully so, moved to the top. And then the next ATLS course, you'll see that.
Yeah, treat the immediate life threat, for lack of a better word.
So if you're actively bleeding. The problem is if you're hypotensive, and if the patient's hypotensive and tachycardic, then you have to, in a trauma patient who's had a mechanism of injury, you have to consider, if you don't see the bleeding, it's internal, and that's this fuzzy part. Yeah. Whether you're going to give TXA or not. What's the downside of giving TXA? Well, it's antifibrinolytic, so you're going to clot, so you got a higher risk. You may have a higher risk of VTE, but thromboembolism, out some time in your hospitalization and beyond. It's not clear that does happen, but it's what the concerns are about that drug. I have no problem giving it.
No, you've always been very supportive of it, and we also give it in within the first hour of injury as well.
Back to the report, I need to know you gave it.
Yeah, that's true.
That's a good point.
That's an important pass-on point, right? What's the bag hanging up? That's an important point.
Yeah, it needs to be communicated because we have double dosed, so I don't want to talk about it, but you have to let us know.
And we've talked about TXA on this podcast before. We're not dripping down clots into someone's blood.
Correct.
No.
We're stabilizing clots.
No. It's doing what it's supposed to do.
Yeah, and we give it to that first hour of injury, I think, is a key point in our protocol to mention. So from the time the injury occurs, we do not administer past 60 minutes. We stay within that first 60 minutes.
It's like the antibiotics for open fractures. The sooner you can get it in the bleeding patient, the better.
Yeah. So that's a great transition to talk about ANSEF, Doc. Thank you.
Hey, Ray, before that, this will kind of run in with the shocked patient and medications. So this would be a good time to do this. Online question here was, how do you best differentiate someone in, I'm going to paraphrase some of this, hemorrhagic shock on beta blockers versus neurogenic shock?
Yeah, it's a great question. Versus neurogenic shock. The one thing is the rest of the body is are they cool? Are they have poor capillary refill, and so forth. The neurogenic shock, you're gonna have pooling in the extremities, right? That's where that's why it's happening. They're vasodilated. So are they vasoconstricted? Are they pale? all those things would have, and then diaphoresis, or that sweat of shock occurs, cold and clammy. So that's what I look for. As a matter of fact, I don't need a blood pressure. If I can feel a pulse at the wrist, it's 80, and if I feel it in the lower extremities, it's probably 80. If I can't feel pulses, then distal pulses. Then if it's at the femorals, is all I can feel, or the carotids, it's 60 or below. And those are the pulse, and that's it. The pulse character is very important to feel. But just touching, you'll see me at the bottom of the bed, taking the boot socks off and pinching the toes. And if they're not blushing, if the capillary refill is greater than a couple of seconds, I'm worried of a shock state. And you can do it on the fingertips too. Just the nail polish sometimes has to come off.
I think that's a great point for all care, not just trauma care. Is
Sure,
touch
it's a
your
quick
patients.
assessment. Yeah.
You can know they've got a fever. You can do capillary flow.
Yeah.
We talk a lot about just this, hi, I'm John, how are you? And I can feel for radial pulse. I know that Caleb's got a reasonable blood pressure.
Yeah.
That takes 2 whole seconds. It's just during my introduction even.
Yeah.
So just touch your patients. You get a great view of their overall health of that individual.
I don't have to have the monitor on to do those things, and that's the physical examination, which unfortunately becomes the nice thing about training. When I trained, we didn't have even CAT scan, so you had to do a fair amount of clinical exam. That exam went on, and history that went on for a while. It was a significant examination head to toe. We probably moved to CAT scan much quicker than we did in the past, because it just now we do a pan scan once we have a stable patient.
Yeah, and I mean, I think the importance too in what you're saying there for EMS and their care is we want to make sure we expose that patient, right, and do a good head to toe, and then we want to cover that patient back up and then make them warm again, right?
And you don't have a CAT scan.
Correct.
We have cats, but they don't scan us.
Well, Ray, you actually opened the can for the next online question here. So, this next question here was how often are EMS trauma patients delivered hypothermic? I'm assuming that to be asked in the vein
that's
in the summer.
Yeah.
In the summer. Oh, in the summer.
I'm taking that.
Well,
to be
in the summer, a good portion of those that do move into hypothermia are drownings or near drownings. I should say near drownings, and they're overnight outside, and especially if they were inebriated or under the influence, they will come in, with low body pressure, temperature. Anyone exposed. Remember that the room, even room temperature, right? You're going to go, especially if you're in shock, you're going to go to that ambient room temperature, especially if you're unclothed. So we'll see it in the summer. Obviously, we're in Cleveland. In the winter, we see it quite often.
I'm guessing the crux of this question was
For summer.
Summer ambient, relative ambient temperature.
The important thing is rewarming, and is making sure you do passive and active rewarming. Fluids need to be warm, and you can use other methodologies. Here's where DPL works. It's not diagnostic, but perineal lavage works. So.
All right.
I'm not advocating it to make a hole in an abdomen and pour in fluids, but it is. And if you're going to pour in fluids, normal saline is acidic and it hurts like hell. So.
All right, we'll talk a little bit about ANSEF. One of the things that we're changing that's happening in our systems right now is it started small, I believe, at Elyria, and because they have the most open fractures in our system, and One of the goals is we obviously want to try to give ANSEF to that open fracture patient as soon as possible. So if they're an adult patient and they have an open fracture, we want to give 2 grams of ANSEF. And, the goal is to get that in 60 minutes of injury. And now that's rolling out to EMS as a whole system-wide. So Parma, Geauga, Portage, all of our hospitals, our whole system is going to get that. So I think that's awesome and innovative that we're doing that, and it really shows how as a system we're working to improve pre-hospital care, which helps the patient long term coming into the hospital. And I think that's a great point for.
Yeah, I do. I think again, my only concern, and this is not a pushback really, but my only concern is it's another task we're giving EMS to do, on transport in a short transport time, as long as it's communicated. It was given. It was not given. Sure. So that we can make sure we follow up with that. But I think I know my orthopedic colleagues, and I've asked this question of them quite a bit. Is they from time of injury, yes, 60 minutes, but the sooner the better. The sooner the better, and an open fracture.
Yes.
And ANSEF's all we're going to go for, because in an open fracture that's contaminated, you'll probably have to broaden that significantly, but that's our job. To inspect, debride, and then make that decision in the operating room. Okay, but
yeah,
and realize often with an open fracture, we'll move, meaning the trauma surgeon will move that patient to the OR, and then have the orthopedic surgeon come in and take over for the bony aspects of this. And often there's maybe a vascular injury as well, especially if there's a vascular injury, getting something down there, because the blood supply is really compromised now.
Yeah, that's true.
I think that not only obviously Parma's got short transport times. Obviously other agents have longer transport times, but let's say you've got an entrapped patient that's got an obvious open fracture and they're hypotensive, it would benefit the patient to give them TXA, give them antibiotics while you're working that 20, 30-minute extrication, get them IV started, get a liter of fluids going on them, help control their pain with fentanyl. There's other things you can do, and that way when you're out, you've already done those things, you can go to the hospital.
And that's an extremely likely scenario out in Geauga County, where we could have farming incidents.
Yep.
And so it's...
Yeah, no.
You could be back in the woods, right? Or something. Yeah, that's
relative to a prolonged transport time, you're delivering therapeutic care out in the field.
Yeah.
And you're doing much more than, say, a short transport time in East Cleveland, where we're either coming in, within 5-10 minutes. So
sure. So do we want to touch on maybe pain control, and then we'll see if Parma Fire has any questions. Pain control for it?
Small doses of IV narcotic, generally now this day and age, fentanyl. So.
Yeah. Typically, we stay with fentanyl. We sometimes move to ketamine, depending on the severity of the injury.
I think ketamine is in my career has been a real transformative agent in controlling agitation as well as pain control. So
yeah, I like opioids as a first line, and then ketamine as my adjunct. The combination works great on most patients.
Yeah, and
transport uses a lot too. That when you give them opioids, they'll
just
use
dosing of ketamine.
Correct, and our protocol says they're 10 milligram aliquots of ketamine to control pain and get them a little bit of.
Yeah, and the nice thing with giving the ketamine or giving ketamine or utilizing fentanyl, I do the same thing. My practice was I usually always started with fentanyl, and then if it was extremely severe, sometimes I would move to ketamine. But the nice part with those drugs in our trauma patient is it's not going to affect their blood pressure, such as some of the other medications in our drug box, and it's not going to negatively impact the patient, such as we never want to give Toradol to a trauma patient is one of the things, we talked about a little bit off camera before we went live. Someone that falls off a roof and has 2 broken femurs is not a Toradol candidate.
No.
And people have to understand that. That's not a good thing. So we really have to...
Not pre-hospital.
No, not pre-hospital. So, those are just some of the things, and it's nice that we have versatile drugs in our drug box that we use for, a plethora of different things, pain control, agitated delirium, those types of things.
Recently, there started being a lot of talk about freeze-dried plasma. Have you read into that at all yet?
Yeah, well, we have thawed plasma already available because of our cardiac program also, uses a fair amount of blood. There's two things I talk about. I think freeze-dried is a methodology to have it available and to utilize plasma. But this is all around, transfusion practice in trauma care. Whole blood is on the rise. The problem with whole blood is our blood supply.
Yeah.
And shelf life.
And shelf life.
Yeah.
Right. Well, and that's exactly the problem is that these products, when partitioned, may help more people than just the trauma patients. But whole blood works in trauma care and is more beneficial and saves lives. The American College of Surgeons Committee on Trauma has come out in their bulletin, and the American College has come out in their bulletin and has backed that statement. And pre-hospital whole blood is on the rise.
Yep.
Yes.
So I don't see how we avoid it here. There's a mortality difference when people get whole blood and the
Faster, sooner. Yeah.
Right now,
the military has proven it time and time again.
there's a logistical problem for us right now.
It's
That's to get
logistical
whole
all
blood.
over the region, but eventually it will have to be solved because there is an advantage.
Yeah.
Right now, we have, I believe, the first program that actually has, they have packed red blood cells, 2 RBCs available for call-outs in the Illyria program. We're looking to expand that to other programs. We're talking internally amongst, if you ever need blood, although you guys probably aren't going to in Parma, but anywhere, the helicopters have 2 units
exactly.
of blood.
Yeah. Exactly.
So if you need blood to come to you,
airmen.
call a helicopter, they'll get it there. We're talking about how do we get it on specialty ambulances to come out to scenes, or just go to your local emergency department. They're going to have units available. When I talk about Harrison County, they've got a 20-minute flight just to get there. So we talk about going to the local hospital. Even though the ER is not going to like it, they're not a trauma center. They're just a small community hospital. But they're going to have more products. They're going to have a doc there. They're going to have more ability to care for that patient, to stabilize even with maybe blood products before you put them on the helicopter to fly out. So we know blood is there. We know whole blood's probably the way to go, but I can maybe help one trauma patient, or you break that into components. You're helping 3 or 4 different people out by breaking it up into components. And then what we do in the hospitals is we just take all those components, mix them together to hopefully make whole blood back again.
Well, it becomes a societal problem, as you've said before. That we need to give back. We need to donate.
Yeah, and UH and Dr. Hill and I believe Dr. Singer, they really spearheaded a lot of that to have blood drives in a lot of the local communities to try to increase the supply because the hospitals need it, and hopefully everyone listening and people in the communities will come donate because it could definitely help save a life.
Yeah, well, in trauma, I think of whole blood as the mother's milk of trauma care. And the thing being is that if you shed blood, you need to give the full components back.
Absolutely.
And that's what this is not a new concept. This has been known for quite some time. It's now the data shows survival advantage. When in an actively bleeding person like a soldier in the battlefield. So we're going to have to come to terms with it.
I believe we have one question from the audience. Yes. Cap.
So we here in Parma, we do rapid sequence innovation, one of a few departments. I think this year we've had 6. Almost all of them had trismus as the presenting complaint of why they used it. And a lot of those are falls. Can you tell me, what's the academy think about pre-hospital medicine using RSI, but more importantly, for all providers, that we should be using capnography to track the trauma patient themselves and see how they're they're doing well in route.
That's a great. Yeah, the answer, and it's the American College of Surgeons. They see relative to pre-hospital care. That's credentialing and a skill set, and so training. And if you have that training and you understand what the complications of providing RSI in the field, and are able to manage those, and what are those management principles, then it's doable. And obviously, it's an airway skill set that you're of a difficult airway that you're going down. So you should evaluate the airway. You have trismus. If you really need that airway, you're going to need to do that, because you don't have a golden hour. You got a platinum 4 minutes, right, to get that airway. So I have no problem with that in a person with skills and credentialed in that airway procedure. When I say credential, is that there's some kind of training and validation of that training. Okay. Yeah. And including administration of the rapid sequence innovation pharmaceuticals. But as far as using it, I think it's excellent to have that skill on the transport. What was the second half of the question?
So the second half is capnography.
Oh,
and the importance
capnography
of
is a standard. You must have capnography. I think end-tidal CO2 is underutilized all over, and especially in determination of death. I mean, if a patient comes in and appears DOA to me, I need the end-tidal CO2 is less than 10, they're dead. I don't even stop resuscitation. So one of the first things in that set of, do they have enough? Do they have an airway? It doesn't have to be an airway that's been an endotracheal tube, a secured airway per se. But as long as they're breathing in and out, we can breathe for them. They have breath sounds. I put an ultrasound on the heart. There's no cardiac activity. And if the end-tidal CO2 is less than 10, he died in the field, and he's going to be dead here too. So it's a DOA, and let's keep it a DOA and not work the case and not do more damage than we can and do damage to others. And the thoracotomy, it can I've seen people get cut from the open chest and the rib cage, and from their instruments. Right? These are not controlled procedures often.
I think that's a great question, and for some of the people that are listening that might not be familiar with our medical control, thank you, Cap, for bringing that up. We have I don't know a specific number, but we have a group of ambulances and fire departments and our EMS services that have RSI capabilities. They've been trained. Their medical directors heavily involved in their training. There's competency training. There's education, but they have the knowledge, skills, and ability, and then there's ongoing competency training with that. So Parma Fire being able to offer that care to that patient that has trismus is huge to be able to get that airway, because if you're unable to ventilate and oxygenate that patient, then what's our next line would be to crike them. So that's a great question. So, and that being able to do RSI is huge in the field, and use end-tidal is excellent.
And if you ask almost anybody, have they done it to crike?
We talked about this.
I have. And because I'm doing tracheostomies as well. But the fact of the matter is it's not a common procedure, and it's incredibly difficult in a back of an ambulance or in the field to do, and you often get lost in the neck, and the next thing you know, you're in a vessel lateral to the trachea. So
that was a great question. Thank you. Any more questions? I have one for Dr. Tinkoff, and I think no more. So we're getting up on the hour. So one of the other questions I'd like to ask, we've talked a lot about things tonight. Dr. Tinkoff, in your experience as a medical director, is there anything that you can see that EMS can do better with pre-hospital trauma care?
I go back to my is communication.
Communication.
Yeah, I think we need to do better on our side too. I think more is lost in that period of time than you can imagine in terms of that transition of what EMS saw and what we need to know. And we want to get on with the resuscitation, and you want to get the heck out of back onto your rigs and back into your service area. So making that more efficient and clearer, and making sure we have the information, and if we're not listening, making sure that there's a kind of a moment to stop and say, look, you don't appear to be listening, but this is what I'm telling you. And we need to know what you know, and need to be. And if you don't think we have it, then yes, look for the senior member of the team, go over and tell them what your concerns are.
That's great. Thank you. I think if we don't have any more questions, I want to thank Parma Fire for having us here at Station 2 today. It's been extremely busy. We got to meet everybody right before we started, and then it kind of fell apart a little bit. We lost most of them due to their busy run volume, but it is greatly appreciated for Parma Fire hosting us. I want to thank Dr. Hill, Caleb, and definitely our special guest, Dr. Tinkoff, for putting up with me for the past hour and answering all of our questions. So we greatly appreciate the conversation, and I think it's
almost my bedtime.
We greatly appreciate the conversation and you sharing your knowledge with us. So thank you very much, sir.
Okay. All right. I appreciate it.
All right.
Thanks.
Thank you, everyone.
Guys.
We'll see you later.
That was fun.